So here you're watching drug-induced sleep endoscopy with this monitoring in a 49-year-old male with history of snoring and choking. You can see he's got a gross TNS on the right side and turbinate hypertrophy on the left, which we have decongested. His body mass index is 30, so he is overweight, and his apnea-hypopnea index on the sleep study is 24, majority of which are obstructive apneas. In the nasopharynx, there are no adenoids. Salpingopharyngeal folds are at least grade 1 by Agrawal's classification, if not grade 2. You can actually, let me just see, let it open up. Right now everything is collapsed. This is the upper part of the velum which is completely collapsed, both AP as well as lateral. I would still grade it as grade 1, between 25 to 75% salpingopharyngeal folds. And you can see the whole velopharyngeal tube, right from top to bottom, slightly vertical palate. The whole thing is collapsing, both superior as well as inferior. This is the superior part, and that's the inferior part. So as I try to negotiate the velopharyngeal tube, this is the lower part of the velopharyngeal tube. You can see, though it is majorly the velopharyngeal collapse, but overall, you can see a little collapse of the base tongue, which is not really significant. It does not require any intervention. That's because of the Bernoulli. Now I'm keeping his mouth closed. When I'm keeping his mouth closed, you can see the base tongue is completely pulled forwards. Right, with the mouth closed, the base tongue and the epiglottis is not collapsing at all, whereas the velum is still completely collapsing. You see this? Very, very clear. Velum is collapsing, but with the mouth closed, there is no collapse of the base tongue and the epiglottis. It's majorly the collapse of the velum only which is causing the effect of constriction. The whole pharynx is collapsing, and it's a tunnel kind of a collapse. Both upper and lateral, upper and lower part of the uvular is collapsing. This is a good candidate for uvulopalatopharyngoplasty with barbed suspension bridge. The length of the soft palate will have to be definitely taken care of, and both AP as well as lateral collapse has to be taken care of, along with turbinoplasty and septoplasty. You can see there's a lot of space on the left side right now because the turbinate is decongested, but the right side of the nose is completely blocked because of the deviated septum. We can do it simultaneously, both the surgeries in one stage, or we can stage it nose first followed by the pharynx. It depends on the choice of the patient. Thank you very much for watching.